I thought I cleared the waiting room. There's some more.
Well, the more the merrier. We're conflicting with the Administrative Reg Review Subcommittee meeting, which a lot of us monitor. So I know we've got a few people that are multitasking here, I think, today. They have moved their meeting time around a little bit during the summer, so hard to know if we're in conflict or not.
I have cleared the waiting room if you want to go ahead and begin.
Okay, thank you very much, Erin, and welcome to you all. We'll call the meeting to order. I'm Sheila Schuster, Executive Director of Kentucky Mental Health Coalition and Chair of the Behavioral Health TAC. So if you're not here for the BH TAC, then you're in the wrong meeting, which happens these days with Zoom. But if you're in the wrong meeting and want to stay, we're happy to have you. And want to acknowledge our other voting members who are here, TJ Lidovic from NAMI, Kentucky, Eddie Reynolds from the Brain Injury Alliance of Kentucky, and Steve Shannon from the Community Mental Health Center's CARP. So we have a quorum and we are authorized to do business. So let me ask the voting members for a motion to approve the minutes of our May 12th meeting that were distributed via email.
So moved. You, Shannon.
That's Steve. Do I have a second, please?
I'll second.
Who's that, Eddie?
Yep.
Okay, great. Any additions, omissions, corrections that you all saw in the minutes? If not, I will ask for a vote to approve the minutes. All in favor signify by saying aye.
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 And opposed and abstentions. So the minutes are approved. Thank you. I have not heard of any issues with the Medicaid single formulary, but I wonder, let me open it up for just a minute because we have some providers on and so forth. Have you heard anything from the CMHC, Steve?
No, I have not.
Any medication problems? Okay. Anybody have anything? Because Dr. Ali and her staff have been very responsive. So if we have any issues, you know, for our folks, it's so important that they have immediate access to the appropriate medication at the appropriate time. So we want to be sure that we don't have any problems. All right, then we'll go on to an update on claims payments for services to dual eligibles. And I think I saw that Lee Geis was on. Are you on, Lee?
Yes, ma'am. I just jumped on for a minute to see if you needed anything. Is anybody having any more trouble with that issue?
Let me see. I got something from, I don't know if Kathy Adams is on from the Children's Alliance.
Hi, Sheila. Yes, I'm on.
Yeah, you had sent me a note that we still had a couple of MCOs that are not publishing or not using the commercial bypass code list.
Yeah, this is Kathy with the Children's Alliance. I apologize. I've been sick with some kind of upper respiratory thing. So we are continuing. There were 2 MCOs that don't have a commercial bypass list, and we had received, our members were able to provide examples of one of the MCOs of those 2, an example where they had provided us with their process when a client has commercial insurance, how to get services paid. And they followed that process and the claim was still denied. So we followed back up and they had received an EOB and provided the EOB, but the EOB didn't say that the service wasn't covered. And that's been the longstanding issue is if either you can't get an EOB from the insurance carrier because it's not part of their package of services, or they'll get you an EOB, but it doesn't say that it's not a covered service, which is what it's required to say according to this MCO. And so there were three options allowed in the behavioral health BHSO billing manual that the MCO referred to. And one of the options was providing a letter where you attest that you had contacted the commercial insurance and that they do not cover the service. And so they submitted that documentation and still the claim was denied. So that member has followed up with that MCO and we're waiting to hear back. But very clearly we've got an actual example of the provider doing everything that the MCO has asked them to do to get reimbursed, and they're still not able to get the claim paid, and it's for TCM case management services.
Well, you need to send that, I think, directly to that specific example, send it in an email. If you can go ahead and send it this week, send it to Angie Parker so that she can assist with seeing what the issue is.
Thanks, Lee. Yes, you can send it to me, Kathy.
All right.
I thought-
We
I
will
thought-
do so.
okay.
Thank you.
You're
And
welcome.
remind me, Angie, it's Angela.Parker.
Angela, I'll put it in the chat. It's Angela W. Parker. Kathy should have my email address, but I'll put it in there.
Thank you.
Thanks, Angie.
Yeah, it seems to me that this is a pretty clear example of the provider literally jumping through every hoop that the MCO is requiring and still not getting a claim paid. So I appreciate that, Angie. I wonder if any of the other folks, Steve, are you hearing, is that your only example at this point, Kathy?
Yes, that's the only one I've received because the majority, what I have heard anyway, is that providers, if they have, well, the particular MCO that this example is with, that they just don't serve those clients if they also have commercial insurance because they can't afford to, because they can't get paid. So in this instance, even though the Medicaid client has commercial insurance, they're not going to get the additional Medicaid services, behavioral health services they're eligible for because the provider won't be reimbursed.
Yeah, which is a big problem. You know, it's the irony of you have two insurance coverages and you have less access to services than if you only had one, basically. So thank you, Kathy. I appreciate your detailing that. Steve, do you have any from the CMHC?
It's the same stories. I mean, we've almost to the point where we focus on the Medicare, Medicaid, dual eligible. The commercial is a challenge. We're trying to process those as we go, but I can get examples, I'm sure. It's just, very little progress on the commercial.
Okay. So I guess the question for DMS then is there anything that can be done from the DMS side to make this a priority, to make sure the MCOs do it the right way? Because what's happening, it sounds like, is that we have fewer providers who are willing to deal with folks if they've got Medicaid and a commercial insurer.
Well, I mean, this is Angie Parker with Medicaid. If it's one particular MCO or if it's off sick, obviously there is that. You can always contact myself and or Jeremy Armstrong DeRossett, who's the branch manager, for any MCO issues, and we can look into it further without knowing the specific examples that you're having. Is it all their claims or is just one-offs? Those those are types of, that's the information that would be helpful as well. We
Okay.
know that not all MCOs have a commercial bypass list. That's something that we have not, mandated, but I do, that is something that they have been working on. We do have the Medicare bypass list, as you know.
Right. We have monthly calls I will add this to every call. The commercial dual eligible piece.
That would be, yeah, I think that would be very good, Steve.
Yeah, I understand from Kathy that 4 out of the 6, Angie, do have commercial bypass lists. Now, whether that's solving the problem every time, I don't know that. And I guess that's something that we need to follow up on. But at least in terms of having a list, my understanding is that 4 out of the 6 MCOs do have a list.
As far as I hear from my members, those bypass lists for commercial insurance for the 4 MCOs that have them is working nicely. It is working well. And so there's no issue. It's just an issue while there are 2 MCOs that don't have the bypass list. One of the MCOs just doesn't have a large percentage of clients, Medicaid clients. So my members haven't had any examples for that MCO. It's just the other MCO that it's a continual problem. And like I said, it's been going on for years now. And most of members just don't serve those clients anymore.
Well, let's do another round of data gathering then. And, Kathy, I'm counting on you from the Children's Alliance because you have so many providers, and Steve with the CMHCs, and Bart as well.
All 14 are on those calls.
Okay, great. But I do think that if there are other providers who are on the call today, and very often we have some of our BHSOs and some of our other groups, that we need to get that data from them as well if they're having a problem. And we know that the problem is more likely to occur with kids having the Medicaid and commercial insurance. I'm sure it's not exclusively, but I think more so.
Right.
So let's put this on the agenda for September. And let's wait to make a recommendation to the MAC. But if we haven't gotten anywhere between now and September, then I think we ought to kick it up to the Medicaid commissioner and so forth.
Yeah, Sheila, this is Bart. I haven't heard as much about, like the other folks, as much about this lately. I don't know that that's an indication that it's been resolved, but I'll reach out to my other groups and get some feedback.
Yeah, that would be helpful. Thank you, Bart. And I encourage everyone to do it. I mean, I think that the current folks over at DMS have shown that if we can get them the data so that they know what to look at and what to follow up on, that they've been willing to do that. And I understand they can't just blanket go on anecdotes and so forth. But let's really make a concerted effort to get that data and get it to Angie.
I think some folks have topic burnout.
Yeah.
Just kind of throw their hands up. We'll figure out what we can do and go from there. And as Kathy alluded to, some folks don't see individuals who are members of that MCO.
Well, I think it would be interesting and helpful, actually, Steve, Kathy, Bart, and others who are on, if you could give us some idea about either a number of providers or the providers that you have in your group with some idea about the number of cases that they're not providing those services. Because basically people are not getting the services that they're entitled to.
Right.
Which is not a good thing. And I think not something that our Medicaid department wants to have happen. So let's, we'll move this up to a higher priority for our September meeting. Thank you for that, Kathy, for that detailed description, and Lee and Angie for being available. Lee, I think this next one is yours as well. The no-show data gathering panel.
Well, yes, ma'am. But I know you have it on there for me and it's still being used. But the largest number of reasons that folks are not showing up is unknown.
Hmm.
So the MCOs, I think, may have something that they can tell you about how they're going to use the data, but that is still the trend. The biggest reason is that they just don't show up. No one knows why.
Is there any improvement or any increase in the number of reports to the panel, Lee? And I asked that because we made a recommendation to the MAC back in March that they make this a regular part of their agenda and that they regularly remind providers to use the portal. So do you have any sense of, or could you report that at our September meeting about what the...
Well, I don't have any sense of that, Dr. Schuster, and unfortunately I can ask for someone to report it at the September meeting. But this will probably be a good minute just to let you all know that I'm retiring at the end of this month. And
Oh,
so there'll be someone else, though, who can respond to that question. And I'll make sure, yeah, I mean, it'll be in the minutes. And so DMS will make sure to pass it along.
all right. Well, thanks for letting us know, Lee.
Certainly.
Congratulations on your retirement.
Thank you.
You have
Thank you.
put in many years of service in Medicaid, and
You'll be missed.
we appreciate that. So thank you. Yeah, and we'll make we'll put it in the minutes that the request is that we get a report at our September meeting about what the reporting numbers look like and who they're from.
So I would suggest, Dr. Schuster, that you ask how many providers
Right.
are actually reporting.
And you all, I think, do I recall that you have them broken out by the class of providers, like the behavioral health providers are there separate from the physical health? Do I remember that?
We have them, we can collect the information by provider type. And so we have several different behavioral health provider types, as
Okay.
well as several different physical health provider types. So we can
Right.
break that out.
All right, that would be great. So that's what I need to ask for. Thank
Yes,
you.
ma'am. You're
Always
welcome.
always good to ask the question so that you it matches the data that you have that can answer the question. So we will do that.
Absolutely.
Yeah, thank you very much. We will do that. Provider credentialing. This is a question again that Kathy brought up, but I think we've all been curious. So House Bill 438, not in this past session, but in the session before that, I think was Representative Ken Fleming's bill, which allowed the MCOs to join a kind of a consortium or some kind of group credentialing alliance. And Angie, if you're still on, I think you were the one that reported on this, maybe at the MOAC, or advised another meeting that 3 of the 6 MCOs are currently participating in that alliance.
Yes, ma'am.
So I guess the question is, do the other 3, is there a requirement that they join?
This is Jennifer with provider enrollment. So
Thank you.
no problem. The House Bill 438, they did actually remove the requirement for the state to have a single credentialing agency. So they're not required to join or utilize the same one. I know that there are a few that do, but they are not required. So what I can offer is if there are providers who are having problems with credentialing, I'm going to put my email address in the chat. They can reach out to me if there's specific problems, and my provider enrollment team, we can try to help and maybe work along with the MCOs to help resolve any problems that they're having.
Okay, that would be great. And Jennifer, is there this alliance or this consortium that 3 of them belong to? Is that accurate information?
Angie knows more about that than I do. I think that's accurate. I'm not sure which 3.
I'm pulling that information up.
Dr. Schuster, this is Stuart on with WellCare,
Yeah,
and I believe the 3 are WellCare, Aetna, and Molina.
thank you, Stuart.
Certainly.
And Jennifer has put her email in. Jennifer, how do you pronounce your last name, please?
It's Dudinsky.
Dudinsky. Okay, very phonetic. Thank you. I don't
You're
think we've
welcome.
met before. We appreciate your being on.
You're welcome.
Thank you, Stuart. I guess then the question is, if there are 3 that have joined this, what are we calling this thing? I call it a consortium, alliance.
Alliance.
Okay, thank you. Does that mean that you all are all using the same criteria? And if somebody applies to one of the 3 of you all, they will be credentialed by the other 2?
What we're actually doing is the bill created the option, it had the requirements, and so it has to be affiliated with a trade association. And so the Kentucky Hospital Association is partnered with Aperture, and they will perform all the credentialing on behalf of all 3 of those MCOs.
Okay.
And any other MCO that decides later to join. But as of now, it's just those 3.
All right. So I still, I'm trying to look at this from a provider standpoint, and since I'm no longer a provider, I have to put myself back in that world. So if I want to be a, say I'm new and I want to be a provider with all the MCOs, can I apply to this alliance and go through the credentialing? And if I'm approved, then I would be approved for all 3 of you all on the behavioral health side?
I'm 99% sure that would be the case.
Okay. So is this relatively new, I assume, Stuart?
Yes, actually, the bill, was passed last year, and then KHA in particular has been negotiating with MCOs, began negotiating with MCOs, and I believe it actually goes live August 1. I could be wrong.
Oh, all right.
I know it's no later than August the 1st. I'm thinking it hasn't quite launched yet, but.
Oh, that's why we're all asking these questions, right?
Yeah.
Well, Aetna and Molina currently have that agreement with KHA / Aperture. I believe it's WellCare that begins in August.
Okay, thank you, Angie.
Oh, okay.
Yeah.
So the other 2 are currently in play.
3, they have their own, either do it internally or another company.
Yeah, I guess what I'm asking is the other 2 that belong to the alliance are Molina and Aetna, right?
That's correct.
They've already been operating within the alliance?
Yes, ma'am.
Okay. All right.
Sheila,
Yeah.
yeah, hi, Tom James. And hi, Stuart, because you and I, we used to work together.
Hi, Tom.
Hi. With all of these things, what it does is to bring all of the material together to make it an easier application process. But under NCQA rules, we each have to have our own credentialing, unless the alliance were to become a delegate of NCQA, which is another hassle. But at least we can reduce the amount of paperwork for people.
Okay, and Tom is medical director with Passport by Molina, just in case people are not familiar with him.
Just about every other plan in the state at one point or another.
Right. So an applicant, a provider who applies for Passport, credentialing knows that they will have the same form and the same requirements
Right.
for WellCare and for Aetna, which is helpful. But they still have to apply to each of the MCOs. Am I saying that right? Okay. Boy, I can see why providers get really confused. So is there any?
This is Kathy Adams again. I had a quick question related to if KHA is an association and they're contracted, I guess, with Accuture or a particular credentialing agency that WellCare, Aetna, and Molina all belong to. What does that get a BHSO, like if that's what Sheila had applied to be, was a BHSO, and she wanted to get credentialed by WellCare, Aetna, and Molina?
Yeah, I guess I'm trying to figure out what's the advantage to the provider. Are we easing the certification credentialing process? Are we shortening it? Are we creating less paperwork?
Less paperwork.
Less
If you-
paperwork.
Yes,
Right, so
just
you don't have to-
applying.
You don't
Sorry.
have to fill out the same forms every time.
So it's standard forms across the three that are participating.
Hi, this
And
is
Well, I was going to say all the performance metrics are the same, established in law and in contracts already.
Okay, and
The
somebody
time-
was wanting to chime in, please.
yes, this is Kat with Aetna. So the advantage is that if they're already credentialed with Aperture, then we can go ahead and load them, into our system once we have the request from them. So it's still a separate process as far as they have to notify us. We would like to add this provider to this group, or we would like to, be credentialed. But if they're already credentialed through Aperture, whether they're with WellCare or et cetera, then we can go ahead and load them. They don't have to re-go through that entire process, if that makes more sense.
Oh, okay, that makes sense.
So the provider needs to contact Aetna, right, Kat Jones,
Yes,
and say, I've been credentialed through Aperture, and then you would go to Aperture and get their information?
that's right. And we would see, yes, they have. And then we just can do what we need to do to get that provider loaded as an affiliate, if it was an individual provider, to get them loaded and added to that contract in the system.
So let me flip the question, Kat. If, again, I'm new in the state, I want to start a BHSO, I want to get credentialed by anybody, and I pick Aetna first, and I go to you all, am I automatically applying through Aperture when I go to you to be credentialed?
Yeah.
They still have, we have to still send that, if let's say it's the initial, to Aperture. But if they've already been credentialed, Aperture would confirm that, hey, they're already credentialed. You don't need to go through that. Or if it's their initial request, it would be, that process. But then let's say they went to WellCare, if they had already gone through the credentialing process, Aperture would confirm, yes, they're already credentialed, and then could go forward from there, adding them to other MCOs.
Would you
Okay.
refer them to Aperture first for an initial credential?
Yeah, that's what I'm trying to figure out. Can people go to Aperture directly to be credentialed?
No, my understanding is that they have to come to us first.
Okay.
So Aperture is just operating in the background, basically.
Yes.
And so the Aperture's contract is with KHA. So does the the members that are, those that are members of KHA, I assume they can go directly to Aperture through KHA, or they submit their paperwork to KHA. I think that's the piece that seems to be missing. Do the behavioral health providers and SUD providers, do we need an association and a contract with Aperture so that our providers can go directly to Aperture, get credentialed, and then automatically be credentialed with WellCare, Aetna, and Molina once you request that?
Yeah, does each association need to have this relationship?
So I mean, I don't think you have to have a contract. The way, you know, again, we haven't launched yet with WellCare. But I think if you go to, for example, our enrollment credentialing page, same with Aetna or Molina, it'll direct you to Aperture. You know, that will be our credentialing entity, our vendor, you know, just like we do with any other vendor. I mean, I honestly, I don't think you have to have any kind of special contractual relationship with them to perform that.
So you don't have to be a member of KHA, is what?
No,
No. I mean, I think that's the question people are going to ask.
no, no. Yeah, no.
Okay.
I mean, KHA and Aperture are performing
Yes.
credentialing on behalf of the MCOs. But I mean, you know, MCOs we have a lot of vendors, so it's just like any other vendor relationship. You're still doing it through the MCO. It's just that we're using a vendor to do it for us.
But you would still have to submit the paperwork then 3 different times to Aperture? If you
No,
wanted
no,
to be-
I don't think so, Kathy. I think what Kat's saying is that you start with one. So let's say you start with Aetna and you get credentialed, and since they're part of this alliance, when you go to WellCare and you go to Molina, Aperture will notify them that you've already been credentialed.
Hey, this is Crystal with Aetna Better Health. Can you all hear me?
Yeah.
Yes.
Okay, I'm sorry. Actually, how the process works is if you wanted to be a provider, you're going to submit that initial application to Aetna Better Health, for example. We send that over to Aperture. We get the provider credentialed, get them loaded in our system. If that provider chooses, hey, I want to be in network with WellCare, Passport, you know, whoever, then they would still take, because those 3 MCOs are using the exact same form. The form that you've already used for Aetna, you would send to WellCare. So you're not having to redo that form. You're using that same form. And then WellCare gets that. They would confirm with Aperture, hey, this provider's credentialed. Then they could proceed with the loading. It cuts out that credentialing processing time, and it cuts out the duplicate paperwork.
All right, that's very helpful.
And it's
Hey,
for
Sheila,
all,
it's,
it's for all services, right? It's not just physical, it's behavioral health services as well as physical health in terms of credentialing, the providers.
Yes, that's my understanding.
Yeah, it's not limited to hospitals or limited to
Right.
physical health.
Primary care. Is anybody? Okay.
Like primary care, behavioral health, everybody, right?
Yes.
Okay. Just confirming, that's what.
Yeah. So the process is you apply to one MCO, that information is shared with Aperture, so you don't have to resubmit the application to the other 2 that are participating.
yeah, hey, Steve, it's Joanne Marston from Aetna as well.
Yeah.
You know, we discussed, I've been involved in setting up the alliance, you know, since the beginning. We discussed trying to have one submission for all 3 to kind of cut down, you know, the paperwork for
Right.
providers and make it a little easier. And that still is in discussion, but the problem is you have to contract with each MCO.
Right.
So credentialing is part of the contracting process. So, you know, you want to outreach to WellCare, Aetna, and say, hey, I want to join your network. Credentialing is part of that. So, you know, we are cutting down, to Crystal's point. We're going to cut down. You know, we're not going to take 30 or 40 days and then WellCare is going to start you over and then Molina's going
Right.
to start you over. So we are cutting down that. And then on the re-credentialing side, you know, as we re-credential providers, we're all 3 going to be on the same schedule. So you won't get 3 pieces of paperwork from 3 different. So it'll really, you'll see some real time savings on the back end from the re-credentialing. Right now, we don't have a way to kind of iron out the contracting piece, because you have to contact each MCO, negotiate a contract, and kind of start from there. So, the point earlier, we're hoping to kick off in August. So I think the more we get into this, the more I think we can streamline and you might see some benefits, but that's kind of where we're at today.
That's super helpful. I really appreciate everyone chiming in. I didn't realize it was quite this new and just being launched in some cases. So,
Hey, Sheila, can I just ask a point
Yeah.
of clarification?
Sure.
So if the organization, the BHSO or the practice, whatever, is already credentialed, already has contracts, with the MCOs, but you're hiring a new employee who needs to be credentialed to bill under your BHSO contract, then when we go to credential that person, we could do one application and say to Aetna, and then it would be the same for Aetna, and Molina, and what's the third one?
WellCare.
WellCare.
Yeah.
Is that right? We would notify those other two. We've already applied through Aetna, and they would just pull that form.
You'd still, the way I understand it is you're still going to have to take that form. It would be one form, but you'd still have to submit it to all 3 MCOs. So we have an intake box for Aetna. You'd submit that over to us. We take that in, we confirm, everything's in place. We put it on what they call a start work file. So we send it over to Aperture to say, hey, we want to start credentialing these folks. So when they get that file, if you had already, been credentialed with WellCare or whatever, they'll kind of align those. But you, as it stands today, you will have to take that same form and send to all 3 MCOs. But it is the same form. You don't have to complete an Aetna one, a WellCare one, and then a Molina one. But you are going to submit to 3 as it stands today.
Okay, so you just save the form and submit it to the other 2.
Yeah, so if you got it saved, you could, I wouldn't see any reason you couldn't put people do it all the time. You could put all 3 of us on the same email. If you've got we have an intake box, if you're sending it to, a WellCare intake and then a Molina, you can put all 3 on the same email with the same form and say, hey, I got a new provider, want to add to my network. You can always copy all of us and it's one email, one form, but it's technically 3 notifications. We don't have anything in place yet where that you can send, and then we're going to, send that to everyone else. So you do have to notify all 3 MCOs as it is today.
Right. Okay.
This is Leslie. I think we need maybe a quick 1 or 2 pager or a FAQ. Folks may have this down pat or they may not, but it sounds like it's a little confusing on the call right now. So we probably need to work with get some information out for folks that kind of streamlines it, if that's okay.
You took the words right out of my mouth, Leslie.
Yeah, I definitely think we can take that. We can take that back and kind of work together. Again, the alliance meets, so all 3 of us together. Happy to take that back and get some information. I think at least going out the gate, it's with some back end work, just trying to streamline the process and cut down some time. But yeah, we can definitely talk about that and get some more information out. That's a little more helpful.
That would be great. I'm going to put it on the September TAC meeting agenda. And if we, had at least a rough draft of a 1-pager or an FAQ, I think that would be great. This is exciting that it will cut down on duplication of paperwork and cut down on time. Time, I think, is the big issue that I hear from providers. Also, if you all can coordinate the research time so that they're all the same, that would be huge. And then if it's just working beautifully, maybe the other 3 MCOs will be so dazzled by the success that they will want to join as well, because it would really be nice to have all 6 in there.
Dr. Schuster?
Yeah.
There's Claire Aaron from KHJ on the call, and she had put in the chat that although she's not part of the credentialing aspect of KHA, that she can connect us with the appropriate KHA staff member to kind of help and facilitate like this, what is necessary to help understand the process better. Thanks.
I appreciate that. Thank you. I appreciate that, Claire. And I didn't see that in the chat. That was going to be my next ask, was whether somebody from KHA might be able to come to our September meeting and be available to answer questions, and maybe Claire, you and I can talk offline about, you know, the timing of that and so forth. But whoever's working on this from the KJ end, I think it's always helpful to have somebody be an active participant to answer any questions, because I'm sure there will be more questions going forward.
Yes, thank you, Sheila. And I didn't really want to interrupt to give you guys a non-update, just that I'm not a part of it, but I'm happy to connect you with those that are and clear up any questions that you have. I already have an email out to the staff member to see if we have any one-pagers on our website that I can put in the chat as a link. I don't know that we do, but if we do, I'll put them in the chat before the end of the meeting today. And I will certainly pass along your request for September.
Yeah, that would be great. Thank you so much, Claire. I appreciate it. And Kathy, thank you for bringing this issue up. The timing was great for us to be talking about it. Next up is telehealth, and there are a couple of things, and I don't know, Leslie, who's prepared to talk about. There's a recent reg, I think the DMS put out on telehealth.
Sorry, Jonathan Scott's on the line for you, Dr. Schuster.
Oh, wonderful. Hi, Jonathan.
Good afternoon, Dr. Schuster.
How are you?
I'm doing good. How are you?
I'm fine, thank you. The guru of all regs. So tell us, give us the reg number, if you will. I meant to look it up, but I forgot to.
Sure. 907 KAR 3170.
And that just went through, right?
Yes, and it is the current reg is now on the LRC website if that's where you normally go.
Yeah, okay. And can you just describe briefly what the reg does?
Sure. So this is our general telehealth reg. And so with this reg, we made some changes, just kind of to catch up to some of the stuff we've learned during the pandemic. So the updated version of the reg, we have added a new section 2 that creates a recipient rights clause. So a recipient has the right to receive care either in person or via synchronous telehealth. That is at the provider's choice. If they are offered an audio only or an asynchronous telehealth visit. Then we have a new section that kind of more clearly states just kind of the general policies as we understand them, and as it complies with House Bill 140, which passed in the 2021 session.
Right.
So that, that was, so as I'm looking at it here, we wanted to be really clear that it's scope of licensure, scope of practice, enrollment with Medicaid as a telehealth care provider. If you are a licensed provider operating within your scope and of licensure and practice, that we believe that telehealth is generally going to be appropriate with some restrictions. The restrictions set by licensure bodies, by billing code requirements, and professional criteria standards. As we were starting to write it, we kept coming up against maybe a couple of pieces of the ASAM criteria up in the higher levels where it really did seem like that was a direct in-person service. So that was kind of the thought we had there. Another piece of it was there are a lot of CPT behavioral health codes that have an audio visual requirement in their definition. So that's why we have that billing code requirement in there. Just that clarification in there. And what are some of our other highlights? Sorry to, I'm trying to.
Is there a reference that an MCO can pay less for the audio?
That's going to be up to the MCO contracting process. That's a House Bill 140. We don't have.
Okay.
That's outside of the scope of our regulation.
Okay.
So along those same lines, Jonathan, I had been in touch with Commissioner Lee, because I keep getting these requests
There's
for
a
people.
lot of
Yeah,
frustration
a lot
over
of-
this bill.
lot of-
Misinformation, I think.
Yeah, a lot of misinformation out there about this reg, and it's
Yes.
doing stuff that's bad and so forth. But one of the questions that I've had from, and this comes up with people for whom English is a second language, and you have to have interpreters and so forth. Is there anything in that reg, and I apologize that I haven't studied it, about the use of interpreters or no, or whether audio only can be offered if there are, you know, significant problems with the recipient having synchronous?
So
Like that, jump like that.
I'm sorry.
Sorry, I didn't hear that. So for interpreters, that would be acceptable. But if a platform is being used that is not friendly to interpretation services, that there's another potential issue there. I would just caution about that.
Yeah.
A synchronous platform that is not allowing for meaningful participation by individuals with limited English proficiency is an issue. So I would mention maybe we should migrate away from platforms that are not fully inclusive. But
Yeah. Well, I've even had some providers say that, and it may be coming from the MCOs, I don't know, that they understood that there was some change in the Medicaid regs or the Medicaid rules about telehealth, and that it had to be in person, had to be offered at all times before telehealth could be offered or used.
no, I have also seen that letter. I have several pages of notes on why I don't think it is correct.
Okay.
But our reading of that, our reading of what we have put into section 3 of that reg is that it is an in-person or synchronous telehealth encounter. There has been language suggested for this specific reg in the past that would have allowed Medicaid recipients to be treated like, but by providers as kind of a second-class citizen group, right? That could be put into asynchronous messaging and not accommodated, or forced into audio-only encounters. So if the recipient wants asynchronous messaging, or not asynchronous telehealth encounters, or if they want audio-only encounters, there is nothing in this reg that prevents that. If they want to participate, if they want a synchronous interaction or an in-person interaction, we feel that it's important that that is guaranteed for them if they want it. It's only if they want it.
Okay.
So, if the recipient approaches requesting an asynchronous or a audio only encounter, provided that it's acceptable via the rest of the reg and the rest of telehealth law as we understand it, this reg is not in conflict with that.
But
So you offer in-person or synchronous, right? That's okay. Because people, I had the same message Sheila's gotten, that you have to offer in-person first. That's not how I read it.
Yeah, that is an incorrect reading.
Okay. So the offer is in person or synchronous.
Yes, and it's provider discretion what's offered. So that, the telehealth only providers are still welcome to participate in the Medicaid program and encouraged to participate. Our language, it says in person or synchronous. So if so if a telehealth only provider is offering only asynchronous messaging and no synchronous elements to their encounters, and a recipient wants a synchronous encounter, then that's what that's focused on.
And synchronous is real time, more or less.
Yes, yeah.
And asynchronous is not. I mean, I guess you were
right.
No, okay.
Right. If it's just like a recorded question and then somebody does a video or audio response and then the provider gets to it later. You know, not that there isn't a place for that in
Right, we understand.
in the medical system, but we want to make sure that there is a real-time option as well for our recipients.
Because, you know, Sheila and I have done a lot of regs over the years, and this kind of blew up at the end of the process. We had looked at it in the initial filing.
Right.
Said, okay, you know, we like telehealth. We don't see telehealth as being restricted in any way in this regulation. And then suddenly, the weekend before Health and Welfare, Family Services, you're going to look at it, you know, everyone get up in arms. And I bet Sheila and I, both our inboxes were full with questions.
Yes.
Yeah, it really rattled everyone, you know,
Yes.
and we were like, no, that's not what it says.
I was also rattled by
Yeah,
that.
I'm sure.
By that.
I got a call last week about this. I mean, it's still out there, you know, that
Yeah.
like you could no longer do telehealth. I said, no.
Right. That's
no.
Right.
a lot of the telehealth restrictions that we're seeing right now are the real ones are licensure board driven.
Yes.
Or some other things like that, or maybe the provider isn't licensed in Kentucky or isn't enrolled in Medicaid.
Right.
Those are the real issues that are coming up right now.
Well, and that leads us to House Bill 188, which essentially, for those of you who don't know this came from Representative Duplessis out of E-Town, and he called me about it. It came from a constituent of his. The mother called him just in a panic because her daughter, who I think was college age, had an eating disorder, and there are so few providers of eating disorder services. And so the youngster was on spring break someplace and had an emergency situation come up. And when she called her therapist, who was back in Kentucky, the therapist said, I can't talk to you. I can't provide that service, which was really, I think, a licensure board interpretation and not anything else. And so House Bill 188 essentially forbids the licensure boards from having those rules. And I guess, and this is not obviously necessarily a DMS or a reg issue, but I'm just curious about, well, you would know, I guess, Jonathan, or somebody who does regs would know for the licensure boards, whether they are changing any of that as a result of 188. Have you heard anything?
I haven't heard anything. When 188 was first proposed, we did have a piece of this reg that may have possibly conflicted with it, and we actually ended up removing that via agency amendment at ours. So we don't think we had any remaining issues with 188, but you know, I would defer to the individual licensing boards on some of this as well. Because
yeah, I think it's something that all of us are going to have to be watchful of, because each of those licensure boards are likely to react in very different ways. They had very different rules to start with. Some of us now are in compacts with other states, and some of these rules are kind of getting to be encased in stone. Some of you know that the professional counselors just passed their compact legislation in 2022. Psychology passed it in 2021. And so you get into multi-state kinds of rules around this. So we're just going to have to keep an eye on this, I think, with the individual licensure boards. But you don't see anything that's in the current reg from DMS that is going to create a problem with what 188 says at this point.
we believe that we're in compliance with 188. And as you were speaking, I remembered something else about this reg that I completely forgot earlier. We're really happy about the remote patient monitoring that we have put in this bill.
I agree.
We put some other language in there and really work to try to make it as broad as possible. So as I know it doesn't hit behavioral health quite as much, but please let us know as it's rolling out what you think of it and how we can make it as effective as possible.
Yeah, that's very helpful. the last question I would have for you, Jonathan and Leslie, when the federal emergency period ends, and there have been, CMS has allowed much more flexibility on platforms in terms of HIPAA compliance and so forth. Tell me what you think would be the impact. Use your crystal ball and tell us what the impact is going to be on telehealth in Kentucky.
That's going to be up to the OCR, Office of Civil Rights, and I really hope that they will, reassess FaceTime and a lot of the other products like that. But because there's been a lot of adoption by that, a lot of access to care that those platforms have enabled. We've tried to keep a running tally of those platforms that we think will be effective at the end. But this also gets into, not only does this get into potential licensure board issues, but it's also going to be provider groups, in-house councils deciding how far they want to go with some of these platforms as well. So that this will be really kind of a patchwork. I think as they step down, I think it may also be a patchwork right now in some ways. But I'm that's going to be something interesting to see. I understand that they may also preliminarily extend a little bit, so that it may not immediately fall off a cliff with the end of the PHE. They may give it another 6 months or 9 months or a year. So I think there's going to be several things in play with the platforms, and hopefully some of these platforms have also
up their game. Yeah.
Right. Because the ball is also kind of in their court to make sure that people can encrypt and secure communications can happen. So I certainly hope that their own infrastructure work is ongoing and people can continue to use them when it's over.
Yeah.
We expect the public health emergency to be extended through October now, correct?
That is what I understand.
No official word though, right?
I just checked that. I just checked their website a little bit ago. This is the time in the 90 days when I start to get really worried and really twitchy. Check it a couple times a day. But I've checked it again a little bit ago. I think we'll probably see something maybe end of day tomorrow. On their website, but we have not heard that it's not going to be extended. So it's possible they will put something else in play, like a 60-day extension instead of a 90-day extension or something like that. I think that there's still some different strategies they may employ, but I haven't heard anything to make me think it won't be a 90-day extension.
All right. Well, thank you so much, Jonathan. We really appreciate it. And I love the idea that, maybe the hope that even when the emergency period ends, that maybe OCR will extend or give us 6 months to kind of sort all this out, because I think you're right. I think the platforms that have been used and used effectively have really allowed services to get out to people. And we can't just drop that, without any, and we don't have broadband.
Exactly.
All over Kentucky, and we're not the only state, I'm sure, but we still have huge deserts where people just can't use a more secure platform. So I'm sorry I've dominated with these questions. Let me open it for just a minute and see if anybody else on the Zoom has any questions, since we have the brain trust here on the reg and so forth.
Sheila, this is Bart. A quick question for Jonathan on the reg, and the broadband is kind of the issue. Good to see you, Jonathan. I haven't seen you for a long time in person, but anyway, I have a quick question and just a clarification. And I don't have the reg in front of me, so I'll paraphrase a little bit. But there was a section specifically addressing audio only and the ability to bill a normal rate for audio only.
Yes.
But it seems like there was some language in there that was allowable if there was a breakdown in service or breakdown in the connection.
Yes.
So, and that makes sense on one hand. My question is what if that's the only option? There is no service, there is no ability to set up a telehealth service, but audio only is the only, because we, as you know, in many parts of the state and some of the folks, and that's one of the things that we're grateful that is still even allowable to be billable within the reg, because but it's been very effective for a lot of folks and over the pandemic. So can you just kind of describe, I guess my question is if it breaks, sure, but if it doesn't even, you don't even have the ability to do it in the first place, and audio is the only option, is that still billable at the normal rate?
Yes. Yes. I think we were looking at some scenarios when this started. So I would say that the first thing is it's not totally clear if there isn't the possibility for some kind of a documentation requirement to come into play with audio only telehealth, with certifying that it was the only option or anything like that. And we've also seen that a lot of the telephonic codes, the 99, the three codes that were, and as well as the G2010 and G2012 codes. So I guess there were 5 maybe that were introduced, but we wanted to introduce the telephonic codes as part of this reg as well. So if a phone call happens and it falls within that limited space, within those limited scenarios, that you can just use that, and there's no documentation requirement beyond what would normally be required. So that was a big piece of it. And then I think the technological issue, I guess it's kind of been cleared up. If it's not a possibility, it's not a possibility, and House Bill 140 says audio only. So we would have to my understanding, we would have to otherwise establish an audio only rate. And that's just coming from DMS. The MCOs may do that differently.
Right. Well, and my information may be old, but I remember when those G codes and we first started into this, that the rate of payment on those, for one, they were really kind of designed for more of a check-in and not an actual therapy session, from what, to paraphrase when I recall, and that they were woefully lower in terms of the rate of payment. So I'm not sure how much, if you are just doing like a well check or a check-in or something for 5 minutes, that's one thing. But if this is your scheduled 45-minute, hour, whatever session, then you can't bill a G code that's pays $15 an hour or something, or whatever the amount is. So that's why I was asking, because obviously the access, it's the access to services that's been a benefit for folks, and to deal with crises and avoid, hospitalizations and those ER visits and those types of things that have been able to be done through the audio only when that's the only option.
Yeah. And as we understand it, that telephonic discussion is really just a very small circle of the overall universe of audio only.
Right.
Telehealth as we see it. But we just included that kind of clarification, and it may end up that in practice it's not something that ever really comes up.
There was a question in the chat, and this may be more for you, Leslie, from Terry Wilson at Bridgehaven, asking if someone who is working under supervision can do telehealth and bill for it.
Yeah, I'm going to check on that. I wrote down her question out of the chat.
Thank
I
you.
just want to make sure before I answer about it.
Okay. And you could let me know, and I'll just circulate to the group.
I've already sent an email, so I'll get right back to you.
All right, thank you. Appreciate it. Any other questions? Well,
Dr.
Jonathan,
Schuster?
yeah.
Dr. Schuster, sorry, Stuart on a well care, not regarding that reg, but something related to telehealth and behavioral health. If you
Okay.
got a moment.
Yeah.
there was a study published on Monday, the Journal of the American Medical Association, an 8-year study of the use of telehealth for members with severe mental illness. And so, you know, they have paranoia, schizophrenia disorder, bipolar disorder, and it looked at the impact of telehealth. And it showed, and this was in 2,900 rural counties, 8-year study, and it found that it increased using telehealth, increased the percent of members getting follow-up outpatient behavioral treatment within 7 days of hospitalization by about 14%. And this was Medicare members. But nevertheless, and this was the study was before COVID, you know, before the big widespread use of telehealth. So anyway, I thought that was really encouraging. And obviously, you know, all the MCOs promote telehealth. I mean, I know, you know, WellCare, we certainly do, but I know all of us, all the MCOs promote telehealth.
Great. If you've got that link to that article or can give us a reference in the chat, Stuart, that's great. Yeah, thank you very much.
Will do.
Jonathan, you're welcome to stay with us, but you probably have other things to do. But we're delighted to have you and your expertise. Thank you very much.
Go check on a public health emergency.
Yeah, keep letting us know about that.
Give us a synchronous update.
That's right. Leslie, our tried and true, where are we on the SUD waiver?
So believe it or not, we have made another step, which is awesome. We finally met with CMS about our proposed budget neutrality. We told them what we were planning. They liked it. So we were planning on having a meeting with them last week to discuss it, but they said they wanted the budget neutrality workbook first to comb through it themselves before they meet with us. So we've got to schedule an additional meeting. But the good news is the new budget neutrality was sent in last week. It does look very hopeful that we might be able to make a few other changes. So excited about that. And I can share those things with you later if that's okay. But yeah, on the home front, that is very good that we're at least getting to that phase with CMS. So I do want to just mention, and I know I feel like a broken record sometime, you probably have heard me speak even lastly on MOAC, our Kentucky authority, our big Kentucky 1115 authority, which is the one that allows us to have flexibility and creativity and all those pieces. The demonstration authority is set to expire September the 30th of 2023. So that means we have to have our request for an extension. So remember, that is a demonstration, and we don't call it a renewal. We call that an extension if it could be any more confusing. So we're doing it. We're requesting the extension. Not a lot of pieces will change in that. We have to get that submitted September the 30th of this year for the extension to go past 23. I know that's confusing. So I've got all these amendments and different initiatives that I'm currently working on right now, right? And we've got the 1115 incarceration amendment that's sitting there in queue that we're currently working on. We do mention that in our renewal that they currently have it and that we will continue on working with that particular amendment. We've been told that no matter what's in queue, they're not going to approve anything until we get the big 1115 authority approved. So it's kind of a little aggravating that the timing hit the way it did, but it is what it is. So I just wanted to let you know that as our timing may be driven for just a little while based on what CMS does and when they do it. So that's where we.
So does that mean that even if they love your budget neutrality on the SUD, that until they have gone through your extension request, is that what you're calling it?
Yes. So
and approve that they won't come back and do a final thing on the SUD?
So it's our understanding on the incarceration amendment, that one's different. They may go ahead and approve it during this current approval, or they may wait until they get they haven't given us a final decision yet. I'm hoping to meet with them at the end of this month again. And we do have this on the agenda. I make sure that this is on the agenda with them every month so that they have to address something with me. But I just wanted to let you know that unfortunately it's getting tied up into Kentucky's authority. And I also wanted to mention too, I'm on the call with you, is that we are also reevaluating on the 1915C side, the residential component. So what we might end up with is pieces from both. I want to make sure that I can address all the population, not just the particular nursing facility or institutional level of care. I want to make sure that I can address all populations in Kentucky that might need it. Does that make sense? So I've asked that we will get a meeting scheduled with you and Steve fairly soon to start discussing that.
Great.
Yes.
Yeah, we look forward to that. Thank
Yes.
you.
Thank you.
Thank you, Leslie.
Yes.
Is there any updated prior authorization guidance? I don't think I've seen anything come through. The last was, I think, May 20th.
No, ma'am, it's still, as you know, July 1st, the SUD services for inpatient went into effect, but there's been no other further updates at this time.
Okay, great. And the interim task force on emergency medical services. So this was House Bill 777. I guess that was lucky. It was the third iteration of this bill. This was the Ken Fleming bill that we worked on, the mental health folks worked on with KHA and with the nursing home folks and with the hospice folks about the lack of transportation from one facility to another. And that task force has been formed. They are actually meeting at 3 o'clock today. So if you're dying to watch something after you get off this meeting and you want to keep listening to behavioral health stuff, that task force is meeting. It is being co-chaired by Senator David Givens and Representative Ken Fleming. And the task force members on the Senate side are Senator Don Douglas, Brandon Storm, and Robin Webb, which interestingly are mostly rural legislators. I mean, Don Douglas has part of Fayette County and he's over there in Nicholasville, but Brandon Storm, David Givens, and Robin Webb, it's not just a rural issue. I just want to point that out to you. On the House side, it's Representative Mark Hart, Michael Meredith, and Lisa Wilner. So we will be in touch with them. They actually contacted me before this first meeting and said, what were the issues? And I said, behavioral health, behavioral health, behavioral health. Number one, that we had EMS and ambulance providers who came to a hospital and refused to take a person who had a mental health condition with a variety of unacceptable comments like we don't have to take crazy people, you know, we're for people that have a medical problem, not a mental health problem, those kinds of things. I also raised the issue of whether there was sufficient training for EMS and ambulance drivers around how to handle people who may be in a mental health crisis, not unlike our CIT training for law enforcement. And I actually don't know the answer to that, but I think the lack of responsiveness to the needs of folks with behavioral health issues is concerning. And my third point question actually was, are we dealing with stigma here? Because if the comments that were made are accurately reported, then I think we've got a real problem. And I suggested that we look at doing some anti-stigma training for ambulance drivers and EMS folks and so forth. I don't know whether any of that will be responded to. The final thing that we heard is that Representative Josh Bray, who was the co-sponsor of, and I've forgotten the bill number, Steve.
Yeah.
Anyway, it was the House bill that looked at the 202A transportation issues, and there were several meetings of a task force. The cabinet was involved in those. The Department for Behavioral Health, Developmental, Intellectual Disabilities were involved. Law enforcement was there. Many of us who are active on the BH TAC or in the Mental Health Coalition were there. And I understand that Representative Bray is going to ask this task force to take on that issue as well. So I suspect that that's what's going to happen. So I didn't see any other meetings of this task force listed on the interim calendar. I looked at August, September, and didn't see them. So I'm guessing that they're going to talk about that today at their meeting. And so I will keep you posted so that you can, again, you can follow these meetings live or archived on either KET, probably on the legislature's YouTube channel. So have you heard anything else about that task force, Steve?
No, they did. Representative Bray, I mean, he wants to be involved in some way at his bill looked at. Also, I mean, if you look at the group, obviously Representative Wilner understands our issues. And Representative Meredith was on the board of Life Skills for many years. So
Right.
I think he's bringing some more information about behavioral health than other folks may realize. And Ken Fleming understands some of these issues
Yes.
as well from
Yeah.
what he does. So I think it's encouraging. That's the group. And Robin Webb. I mean, she's.
I was going to say Robin Webb, Senator Webb certainly knows this and very often talks about her work as an attorney when she's not being a state senator and talking about some of the mental health issues. So I think we have some people. Senator Gibbons is always approachable, I think, very thoughtful, and was willing to take this on as a co-chair, which is, I think, positive. I didn't have any recommendations for the MAC meeting. Do any of the voting members of the TAC have any recommendations for the MAC meeting?
I do not.
Okay. Eddie or TJ?
None here.
No, I don't have anything.
All right. Are there any suggestions from people on the Zoom? I think we have a couple of issues that we're going to carry on for our September meeting, particularly around the single credentialing and the dual eligibles for sure. And I think we want to keep an eye on the telehealth regs and the impact of House Bill 188.
Well, I was wondering, is there a recommendation around some kind of maybe one pager about the telehealth situation to help address some of the concerns?
I think, and when you think about it, telehealth is not just behavioral health, it's physical health, and it's probably
Right.
not dentistry, but certainly for the MAC. Do you want to make that motion, Steve?
Yeah, I'd recommend that the BH TAC ask that recommend to the MAC that Medicaid provides a one pager on the recent telehealth regulation to be distributed to both providers and consumers.
Okay, particularly important for consumers since
Yes.
there's kind of a recipient rights there, I think.
Mhm.
Is there a second, either Eddie or TJ?
Yeah, I will second it.
Thank you. Any discussion?
Dr.
For
Schuster, if somebody
yes,
send me that recommendation in writing prior to the MAC meeting, I would appreciate it.
yes, yeah, we'll do that, Aaron. Thank you. All in favor of making that recommendation at the next MAC meeting, signify by saying aye.
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 All right, aye. Thank you. That's a great recommendation, Steve. Appreciate that. So under old business, we did get a report that the
You had
MCO,
recommendations for the September BH TAC. We have two of those, right?
yes, we've got the, actually we've got three. Remind me what we have. We have the credentialing. We have the dual eligibles.
Yes.
And then those of us that have been working on the targeted case management data study are going to have an opportunity to meet with the commissioner, and I would hope that we can make a report at the September meeting on that study. So we're going to have a very full agenda in September, but all important issues. So under old business, I think the MCO audit situation appears to have improved. That's what I'm hearing from folks. And I think our discussion at previous TAC meetings have been very helpful with the MCOs. Is there any new business? Is there anything that we should be considering that we're not considering? Let me just go back and remind, thank you, Leslie, for taking on that question about whether a supervisee can do telehealth. That would be important for us to disseminate as well.
Yes, ma'am.
Yeah. Hearing no new business, nothing new under the sun, as they say. Hard to believe. We will have to carry on without Lee, guys, but we wish her well. The next MAC meeting is July 28th, 10 to 12:30. And again, those are available via Zoom, and I'll send that Zoom link out. I really think that those are helpful informations. You get quite a detailed update from Medicaid Commissioner Lee and answers to the questions that the MAC members have. So that's available for anyone who's interested. And then our next BH TAC meeting will be September 8th at 1 o'clock.
Dr. Seuss,
Yeah.
I hate to be a pain, but is there any way that TJ could turn on his camera and you guys could vote on the recommendation again? His camera was not on, and I just want to make sure we're within our open records regulation.
All right.
Sorry about that, guys.
That's all right. TJ, we need to see your smiling face.
Oh, goodness. Well, I've just been working from home today and I'm not very presentable.
Well, it is the requirement of I had forgotten about that, Erin. Thank you for reminding me.
I'm sorry.
So we're not going to look at what you look like, but let's see. Steve, you made the recommendation that the BH TAC, that the MAC asked DMS to issue a one-page description of the recent telehealth reg, and that it be provided to both providers and recipients.
Right.
Medicaid members. And that
Okay.
was,
Well,
that
if I need to come on camera to constitute a quorum, I'll be glad to do it.
all right, we'll do that. Because
Okay.
Eddie seconded that. So now we're going to call for a vote. So are you on camera?
I can be.
Okay.
Well, unable to access camera. I don't know. Oh, I need to change the setting, I think. Hang on just a second.
Sure.
Sorry. Yeah.
Not to put you under any pressure or anything, TJ.
I'm sorry. I just want to make sure we're covered.
Yeah.
Okay.
Dr. Schuster, if I may, while he's working on the camera, the meeting that I set up for you to discuss the targeted case management analysis on the 29th, if you need to forward that, I think I had one email I couldn't find. So
Yes, and I've sent it on.
I was just double checking. I wouldn't want them not to get invited. Thank you.
Yeah, thank you. I appreciate that. And I did send it on, so everybody should be in the loop on that. Thank you.
Thank you.
Okay,
Are you on now?
I should be.
Yes, I see him.
Okay.
All right. Yes,
Yes.
okay, there you are. Thank you. So all in favor of making that recommendation to the MAC, signify by saying aye.
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 Aye. All opposed, like sign. Motion carries. Is that what you need, Aaron?
Yes, ma'am. Thank you.
All right, sure thing. If there is no other business to come before the TAC, I'll give you all back 35 minutes. How's that for a great deal? Stay out of the heat. And thank you all. We had some excellent discussion, excellent response from DMS on a number of things, and I think we're making progress. So I appreciate you all, and thank you, Aaron, for your facilitation and so forth. So we will see you all in 2 months, and again, feel free to join the MAC meeting and monitor that as well. Thank you, and have a great day.
Thank
See
you.
y'all.
Have a
Bye-bye.
good afternoon.
Thank you.
You too.